In the last lecture of this chapter, I would like to talk about a different form of endocarditis, the so-called abacterial or aseptic endocarditis. It is a bit different from the other forms we discussed previously, simply because in this case we do not have any classic vegetations which are infiltrated by bacteria, but in reality it's more a thrombus on a valve. Even though the pathology is different, the prognosis is still poor, but this time not because of the destruction of the valve, but simply because patients who get aseptic or abacterial endocarditis usually have a very severe underlying disease. Non-infective or non-bacterial endocarditis can occur in the state of marasmus, if we have hypercoagulation, and in the so-called Lippmann-Sachs endocarditis. This here is Emanuel Lippmann, who was a very famous physician at his time, who did a lot of work on bacterial endocarditis, and who, together with his co-worker Benjamin Sachs, also discovered or described the so-called Lippmann-Sachs endocarditis. Sachs was actually an interesting personality who had many other talents as well. Later on, he switched to the movie industry, where he worked as a technical consultant. Here you can see him together with Cary Grant. Back to the echocardiogram. What do we see? Well, not very much actually. This is such a patient. All we see is a thickened valve, and if you look closely you can see that there are small structures on the mitral valve. Subtle changes indeed, but later on I'll show you a transesophageal study of the same patient, and then you'll believe me that there really are vegetations on the mitral valve. But what is more important, at least in this patient, is the fact that there's also some form of valvular destruction. Here you can see mitral regurgitation. Now this is the same patient and his transesophageal study. Now you will see that the valve does have structures, vegetations, which are typically located not on the atrial vicinity, but more on the ventricular side of the mitral valve. So the typical characteristics of abacterial endocarditis, and in particular also of Lippmann-Sachs endocarditis, is that we have some degree of valvular thickening, mild or moderate regurgitation, and only small vegetations which are typically located on the ventricular side of the valve. The diagnosis of non-bacterial endocarditis is always a challenge, particularly since transthoracic echo only has a poor sensitivity, and because it is sometimes difficult to distinguish the changes we see on the valve in these patients from normal degenerative pathologies. But when should you suspect Lippmann-Sachs endocarditis in the first place? Well, in the setting of SLE. Approximately 11% of patients with systemic lupus also have some form of valvular pathology. And this is from a publication published 2008 in the Journal of Rheumatology, which shows you how sensitive transthoracic echo is for the detection of Lippmann-Sachs endocarditis. In 81 patients with documented Lippmann-Sachs endocarditis, transthoracic echocardiography only had a sensitivity of 11% for the detection of vegetations. However, 63% of patients had some form of valvular abnormality. The valve which is usually affected is the mitral valve, causing mitral regurgitation, sometimes also in combination with mild forms of mitral stenosis. The aortic valve is much less commonly affected. Again, usually we have aortic regurgitation and sometimes mild degrees of aortic stenosis combined with aortic regurgitation. The tricuspid valve, at least in this study, was only affected in 3% of cases. The presence of Lippmann-Sachs endocarditis is associated with disease duration and the activity in patients with SLE, with thrombosis, stroke, thrombocytopenia, anticardiolipin antibodies, and the antiphospholipid syndrome. It is an autoimmune disease against phospholipids, and we usually have elevated levels of anticardiolipin antibodies, anti-beta-2 glycoproteins, and the lupus anticoagulant test is positive. We can distinguish a primary from a secondary form. Primary is present if we don't have another cause of the antiphospholipid syndrome, and secondary occurs, for example, in the setting of a systemic lupus. It can also occur during pregnancy, where it can lead to several problems such as miscarriages and stillbirth. And finally, what are the typical echocardiographic findings? We saw this image already: valve thickening, vegetations, but also mural thrombus. So not necessarily do these vegetations have to be on the valve itself. Spontaneous contrast, and left as well as right ventricular dysfunction. I personally believe that more patients have abacterial endocarditis than we think. The reason we don't see it is very simple. We just don't routinely send patients who are very sick, merantic patients, to TE. And we don't routinely perform TE studies in patients who have a systemic lupus. Still, I think it's important to know that this pathology exists, because if we do see structures on the valves in these patients, we have to know how to interpret them.